I'm Matt King. I'm a pulmonologist at Meharry Medical College. I previously worked at Vanderbilt with a physician named Dr. Robert Miller, who was asked to evaluate several soldiers who returned from Iraq and Afghanistan with problems with exercise. They could no longer run as fast as they once could or as far as they once could. They used to be able to run 7-8 minute miles, and after returning from deployment could no longer meet their physical fitness testing, and many of them were actually medically discharged out of the military and no longer able to continue to serve. Dr. Miller and I evaluated these patients at Vanderbilt. We ran a battery of tests that are pretty standard for lung problems, and many of them we could not identify what the problem was. So we had to send them for a surgery where a piece of the lung was removed so that we could look at it under a microscope and actually identify what the problem was. We found that 38 out of 49 patients who had these surgical lung biopsies performed had a condition called constrictive bronchiolitis, and really that's just a fancy name for scar tissue in the airways of the lung that make it hard for you to breathe. So as time went on, we began seeing more and more of these soldiers who were having trouble with exercise and couldn't exert themselves, couldn't meet their PFT times, and sometimes were evaluated extensively, but no diagnosis could be achieved. So even with people that had very normal appearing tests like lung function testing and chest x-rays and CAT scans, we would send them for lung biopsy and still find the same problem. Constrictive bronchiolitis is virtually unheard of in young, healthy patients with no other medical problems. The standard patient with constrictive bronchiolitis is someone who has received a lung transplant, someone who has long-standing lupus or rheumatoid arthritis, and on occasion has been identified in patients that have had inhalational exposures like chlorine gas or mustard gas, or in one population it was a chemical called diacetyl, which is used in microwave popcorn production. But in patients that are young and healthy and don't have a clear exposure event, it's virtually unheard of for this condition to present. Well, I think that soldiers and vets are, especially the active duty military, are very different from the average American. They exert themselves a lot more. They push themselves physically in ways that I don't, and I'm sure most Americans don't. I would never really try to run a 7-minute mile, but these guys are required to. So when you push your body to extreme exercise capacity, then you notice more subtle changes in what you can do. So you notice if your mile time falls from 7 minutes to 8 minutes or 9 minutes, whereas you wouldn't notice if you're just walking up a flight of stairs or carrying your groceries in, or walking out to the corner to catch a bus. You wouldn't notice those subtle changes in your lung function. So I think that we're dealing with a population that's really more closely approximated to an elite athlete than to an average American. Unfortunately, the tests that we use compare people to average Americans. So in our study, when we compared to average Americans, we didn't notice any major abnormalities in their pulmonary function tests. But then when we compared them to soldiers that had not been deployed to Iraq and Afghanistan, we showed that our patients' pulmonary function tests were significantly worse than people who had not been to Iraq or Afghanistan. I think that, first of all, there's already been a lot of progress in this area with recognition that there is a problem. But unfortunately, the way we handle it has not been standardized. And I think that right now we operate in a very inefficient system where people will go see a doctor and maybe have 1 or 2 of these tests done, and then go see a different doctor and have another 1 or 2 tests done. And nobody is really sitting down and looking at them comprehensively and seeing all of their medical tests. And I think that we need something along the lines of a center of excellence where we can refer patients to, Washington, D.C. or Denver or whatever city it may be, where there's a group of established experts and professionals that know all of the ongoing issues, like constrictive bronchiolitis or post-deployment asthma or other post-deployment issues that are arising. And then they can do a more coordinated approach and gather all the information in an efficient manner to be reviewed by people who understand everything that's going on. That way, people aren't seeing multiple providers getting many different tests and often being told that there's nothing wrong with them or that they need to exercise more. When in fact that's exactly what these people are trying to do, is exercise more, but they can't, and they want that to be fixed.